Okay, so I'll start with the welcome. So thank you everyone for joining our February webinar. Before we do get started, I would like to acknowledge that APSAD, who some people are joining from over east, acknowledges the Gadigal people of the Aurora Nation, who are the traditional custodians of the lands on which the webinar is hosted. I also want to acknowledge that I am chairing this session from Noongar country, and that the Whadjuk people are the traditional custodians of that country, and wish to pay my respects to elders past, present and emerging, and we continue to practice their values, beliefs and knowledge. We also want to recognise that APSAD, we also do include New Zealand as part of APSAD, and so we want to respect also the Maori as Tangata, I'm sorry, I'm going to stuff this up, Whenua and Treaty of Waitangi partners in Oirarua, New Zealand as well. Sorry for butchering that or any of the other things I've butchered, but I would like to acknowledge everyone today. We also wanted to add this disclaimer here. Maybe it's on the next page. Apologies. So I want to introduce our two wonderful speakers first, who I'm really grateful agreed to join us today. I've had the pleasure of working with both Professor Raja Mukherjee and Dr. Alex Thompson in other roles, and I want to formally introduce them, just give you a little bit of background on each of them as well before we do get started. So Professor Raja Mukherjee is an adult learning disability consultant psychiatrist for Surrey and Borders Partnership NHS Foundation Trust, with interest in management and development of developmental disorders across the lifespan. In September 2009, he started the first NHS-based specialist FASD behavioural clinic, and since then has seen over 250 cases for specialist second opinion as a national referral service. Professor Mukherjee also completed his PhD on the subject of fetal alcohol syndrome in 2014. He also has been invited as an advisor to the BMA Board of Science, the Department of Health and the World Health Organization on the subject of FASD. In 2015, he gave evidence to the first all-party parliamentary group on FASD at the House of Commons, and continues to support national clinical developments related to FASD. Professor Mukherjee is a member of the NICE Quality Standards Group for FASD, and currently the only UK representative to a US NIH-sponsored initiative to consider the research criteria for FASD. Also in his own time, he volunteers as a medical advisor to various FASD charities in the UK and internationally. And in 2021, he was made an honorary professor at the University of Salford related to his work on FASD. And he's also an honorary research fellow at UWA and contributes to the FASD grad cert, or has for the last 2 years. But in his wider work, he's currently the clinical lead for adult neurodevelopmental service provided by Surrey and Borders, including adult ASD and ADHD services across Surrey, Hampshire and Portsmouth. And lastly, he is an executive committee member of the RC Psych on neurodevelopmental disorders, taking over as finance officer from July 2021. So that is just a small snapshot for Professor Raja Mukherjee. And we also have the wonderful Dr. Alex Thompson joining us as well. Alex is a consultant child and adolescent psychiatrist with WA Country Health Service in the Goldfields camps, working across the Kalgoorlie and the Esperance sites. He is a fellow of the Royal Australian and New Zealand College of Psychiatrists and an accredited member of the Faculty of Child and Adolescent Psychiatry and section of the Youth Mental Health. He obtained his first medical degree at UWA and is trained locally to complete his fellowship and certificate advanced training in child and adolescent psychiatry. And he has further postgraduate qualifications in child and adolescent mental health from the New South Wales Institute of Psychiatry, Family and Relationship Therapy from the William Street Family Therapy Centre, developmental trauma from the Australian Childhood Foundation, and graduate certificates in both autism diagnosis and fetal alcohol spectrum disorder from UWA. And so his special interests include the mental health intersections of neurodivergence and the female autism phenotype. So two very knowledgeable and very experienced psychiatrists who'll be sharing their wealth of knowledge with us today. So thank you so much to you both for joining us. And as I mentioned, I'll be your chair, representing the Australian and New Zealand Clinical Network today, affiliated with EWA also. Okay, hopefully this will click on. Of course, the slideshow is not working. There we go. So this is a disclaimer I was mentioning earlier. So just wanted to mention that the views expressed by the presenters and the speakers are not necessarily the views of APSAT, and the Society doesn't accept any responsibility for any information, research, recommendation or advice presented. And lastly, before we do get started, I did also want to place this slide here about joining APSAT. So towards the end of last year, you would have seen, if you're part of the Australian and New Zealand FASD Clinical Network, you would have seen that email was getting retired, and that we'll be using FASD Hub as well as APSAT as our main kind of ways of communicating information. And so APSAT really does depend on the members and their contributions in order to be able to deliver these trainings and workshops for us. And so if you do enjoy this webinar or have enjoyed other webinars that we've presented in the past, you can help us by contributing and learning more about becoming a member through this website here, or just contact one of us if you'd like some more information. Lovely. So I'm going to stop sharing this little presentation. And to start off with, we'll have Dr. Alex Thompson, who is going to take us through a first set of slides. Then we'll switch over to Raja, who will be presenting on some of the evidence base, and then we'll come back to Alex for some further thoughts before we finish up. And so hopefully we'll have some time for questions at the end. And so I'll hand the reins over to Alex. Thank you so much.
Thanks so much, Kirsten, and thanks to everyone who's taken the time out of their schedule. I know we're all busy in today's professional space, so I really do appreciate your time. Let me share my screen, and then we can start from the beginning. Oh, sorry, am I done? Let's just swap that. Lovely. All right, I just also wanted to say how humbled and privileged I am to be presenting alongside Kirsten and Raja, who I finished the grad cert last year, and so I've learned an immense deal from both of them, and their advocacy and their clinical acumen regarding FASD as well as other things has just been an amazing opportunity. And now to be able to come before you and talk through some of how I've taken that knowledge and used it in my own clinical practice, it's a real both a humbling experience. So thank you for that. All right, I would like to give my own acknowledgement of country, if that's all right. I begin today by acknowledging the traditional custodians of country throughout Australia, on which we meet today, and pay my respects to their elders past and present. I recognise their continued connection to the land and waters of this beautiful place we call Australia, and I acknowledge that sovereignty was never ceded, and I extend that respect to any Aboriginal and Torres Strait Islander peoples here today. I'd also like to take a real moment to acknowledge the people who've joined us who bring expertise by experience, the individual and collective expertise of those with a living or lived experience of fetal alcohol spectrum disorder. Every story we hear and every experience that we have shared with us helps to develop our understanding of the care that's required to best meet the needs of those living with FASD and their carers. I also put this slide in. I was in a school meeting not too long ago, and the continued narrative that I thought I was receiving was that we need to fix the child. The medication's not working. Why are they behaving like this? And sometimes, things can come to us in moments of heat, and I probably have this is a pastiche from various sources, but ultimately, when we talk,
sorry to interrupt. We actually can't see your slides.
Oh,
sorry about that. We weren't sure if you were sharing yet, but I think, yeah, you're talking to slides now, so we can't see them. Sorry.
I do apologise.
That's all right.
Oh, well, I hope I haven't been too offensive with my face, but anyway.
No.
There we are.
Perfect. I think that's working.
Okay, for current slide. Is that good, Kirsten?
You might as well switch the views for
Yes,
you.
thank you. Well, I'm glad we practiced beforehand.
Thanks, Alex.
Sorry, no worries. Thanks, Kirsten. So as I was saying, was in a school meeting, and with the focus was on, as I said, the various deficits within the child, and the child had FASD as well as some other neurodevelopmental difference. And I just wanted to say that ultimately, no matter how much today we talk about disorders and we talk about deficits, disability is not a child's failure needing to be fixed. It's an environment yet to welcome all abilities. So I just want us to hold it that it's always a strengths-based approach, in my opinion. But today I'll be talking a lot about disorders. But please, I don't want that to get missed in the talk today. Okay. So the plan for today, for both myself and Raja, is I'll talk at the beginning about a case presentation. So a 10-year-old boy who was re-referred to our service in June of last year with established diagnoses of ADHD and PTSD. And then I'll talk you through the journey that we went on and continue to be on to get an NDIS recognised diagnosis of FASD. I'll then hand over to Raja, who will take us through the psychiatric and neurodevelopmental comorbidities or co-occurrences. And then I'll just briefly touch on the regional context and the challenges and opportunities that provides, how we diagnose without a specialist service, or how we're attempting to diagnose without one, how we work as a MDT despite being in silos per se, and then how to get the best prescribing practices and working alongside GPs and paediatricians. And then some time for question and answer as well. Okay. So I want to introduce a young boy, 11 years old, called Benjamin. And obviously his name's changed and to protect confidentiality. He lives with his grandparents, who are his carers, though no formal court orders are in place. And he's been in their care on and off since he was 6 months old. There was significant family domestic violence, and after the biological mother was successful in her ongoing attempts to escape the violence that was perpetrated against her by his father, unfortunately, there was some personality vulnerabilities and other emotional dysregulation on the mother's part. And so there was ongoing exposure to physical and emotional abuse, as well as from the various various other men that would live in the house at the same time. That was an ongoing tension that Beverly and Ryan never wanted to pursue formal custody arrangements. However, that had its own challenges, as I outline here, that in January of last year, on New Year's Day, actually, the biological mother appeared at the house unannounced to regain physical custody. Police were called, and although one could argue the mother had legal right to the child, the police were able to de-escalate the situation. Rational thought, one could argue, was re-established, and so the mother left, and he stayed with the grandparents. However, there remains an ongoing worry in this young boy that his mother will turn up unannounced and take him. So the developmental history, nothing in the gestational period, but Benjamin was born at 37 weeks by emergency C-section following a failed reorientation. So he was a breech presentation and they couldn't reorient him. He went into fetal distress and he was delivered by cesarean. There were no reported concerns of any social emotional development or concerns. Grandma was able to talk about there was some evidence of shared attention, etc. As I mentioned, the lack of formal family court orders were an ongoing tension. And obviously one does a very gentle screening for other kind of neurodevelopmental disorders, and there were some sensory aversions present, but no other salient repetitive behaviours, cognitive, I know we say rigidity, but I'd like to say viscosity, and no other niche immersive or idiosyncratic interests throughout his 11 years. He loved woodwork and being outdoors, and his grandparents and him would often go on long walks to regulate as well. So the psychiatric history, just gleaned from his notes, he wasn't an active client with our service when he started. He was one of those, not one of those rather, he was a boy who was re-referred every year to get what we call our Schools Plus letter, or our individual disability allocation funding. And then what would happen would, the service would say, well, there's no actual mental health. This is what the service would say, not necessarily I agree with it. The service would say there's no mental health or true mental health concern. This is neurodevelopmental in nature. He needs to be managed by paediatrics. But obviously he needed his PTSD diagnosis to get the funding. So he was diagnosed with combined type ADHD by the town's local paediatrician, who does fly in, fly out. And then he was diagnosed with, on paper, PTSD by his local CAMS at age 7, but his symptomatology were closely aligned with Van der Kolk's developmental trauma disorder. There wasn't any re-experiencing phenomenon or other symptoms that would match up perfectly with a reaching PTSD threshold. But obviously, knowing the limitations of the system, PTSD is a much more palatable diagnosis, and it's recognised in the DSM-5, obviously, where DTD isn't. When I met him of last year for the first time, he came in on a long-acting stimulant with some short-acting dex to top that up. The previous psychiatrist who'd seen him had commenced him on sertraline as well as some aripiprazole. And then he had some clonidine at night. He had quite significant hypnic jerks where his grandma described that he would literally jump off the bed and then on occasion also wake up due to the severity of the hypnic jerk as well. And he was on about 100 micrograms of clonidine. On referral, his current services included a fiercely passionate advocate in his GP, that fly in, fly out paediatrician, and a very supportive school, but really the school was did not have the resources, despite their best intentions, to completely provide that wraparound care that this boy needed, in my opinion. So as I said, current concerns, emotional dysregulation, a lot of hot aggression, as we would say, nothing cold or premeditated in terms of cruelty to animals, and other thoughts of planning or homicidal ideation, anything like that. It was just, he would be fine 1 minute and then intermittently explosive the next, and then would damage property and become aggressive in those moments of emotional dysregulation. He remained hypervigilant or hyper-aroused, one could argue, and he was always wondering where his grandmother was, if she was in the vicinity but out of reach as well. As I said, he had physical aggression at times, the insomnia with night terrors, and then he had also some learning difficulties at school with some trouble socialising. His best grade was a D in physical education, and it also had multiple suspensions for property damage. So as I said, June 2022, he was re-referred, and the referral by his GP, long story short, the medications aren't working. The stimulant's not holding him. He needs to have his medication reviewed, and he needs a support letter for his IDA renewal. The social difficulties, although I would argue they were due to kids being afraid of him because they were worried they were going to hit him he was going to hit them, I should say, if he became dysregulated. That was then distilled down to, well, he needs an autism spectrum diagnosis because that's the only other explanation for what's going on. And then, as the planets would align, to use that turn of phrase, here comes Alex after 6 months with the graduate certificate, and he says, has prenatal alcohol exposure been investigated? And it hadn't. So one, I gently explained to his case manager why an exploration of the prenatal alcohol exposure is so key, explained the rationale behind that, and then we put an audit C to the maternal grandmother, and they came back as a high-risk category. Even on my initial review, when I met him through telehealth due to where he lived, one could see that there was some semblance of the 3 facial features, although one wouldn't want to jump to that just on the telehealth as well. I want to say reorient or shifted the thinking away from the grandmother who thought that he would have bipolar, but presented her with this diagnostic construct of disruptive mood dysregulation disorder, which I think, as a lot of us know, aligns very much more closely with the emotional dysregulation these children experience, much more than any kind of bipolar diagnosis would entertain. So I explained that we had the ADHD diagnosis and we had DMDD. So we have 2 out of the 3, but no one had ever bothered to do any kind of psychometric assessment. This was a very much behavioural trauma focus with a school who was running out of resources, and the narrative that was written was this boy needs more medication, this boy needs to have more suspensions, and potentially we had the I don't know what his formal title was, but the exclusion officer was coming along to discuss possible expulsion. And so I will leave it there, but on that note, we undertook a journey to get him a FASD diagnosis. I'll stop sharing and hand over to Alex.
Right, let me start sharing then. Thank you, Alex. Can you see that?
Perfect. Thanks, Raja.
Okie dokie, good. Right, so thank you very much for inviting me to come and speak to you. I was saying to Kirsten that we had Liz Elliott speaking to one of our meetings recently, so we're all swapping around. Just shows how small the world has become, that we can both do this, me in the morning and sort of her in the evening, but for us. But it's a real pleasure to join you. I'm going to cut down my bio. It's too long, and I get embarrassed every time people talk about it like that. But it's a real pleasure to come and join you and to show it. So what Alex and I agreed is that that Alex was going to frame this in terms of a clinical context, and what I was going to do is to present some of the science and the background and some of our thinking that we've done around some of these areas, being one of the psychiatrists in the world who has specialized in FASD. It's something that I've obviously spent a lot of time thinking about, and my journey into this was very much around the neurodevelopmental overlap and the trauma, and how do we understand complex trauma within the context of that. And I know there's people in Australia who've done some work around this as well, and so hopefully we'll be able to demonstrate our thinking as where we got with that. From my conflicts of interest slide, I don't have any conflicts of interest other than sort of the fact that I get paid by my trust and nothing else. Anything else goes back to the team, and other work is unpaid. So what we're going to go through today is to thinking through my journey and where I started from, and the questions that we asked going to a conference in 2003, and where I left saying, well, why is this not autism and ADHD? That was my background. FASD was not my background. I'd heard of it, but that was about as much as it got. And to be honest, I was where most people are back then in terms of it being a condition, but not something that had much relevance to the people that I was seeing. Interestingly now, and this is what happens to all of us in this journey, as we look back, we start to recognize people who we would have probably thought were FASD cases if we really think about them, just we've missed them. So we're going to go through and think about this being a brain-related disorder very briefly, and then think about how that fits and why we may be missing certain things, nature versus nurture, and then think through complex trauma and how that fits before we finish. So the first thing I need to always persuade people, this is a brain-based issue, and you have to think about the brain first, because if we don't and we think just about environment, we're going to miss things, because underlying everything we do is the processing of how the brain works and how it processes the environment that we're in. So you cannot take that away from the context, and you have to understand what's going on. And so just a few slides to try and highlight that, and those of you who have worked in this area for a while will be very familiar with this kind of stuff. So, but for those of you less familiar, what we're talking about is a situation where we now recognize that there are very clear deficits in individuals with FASD that are consistent. So these are taken from the CFAS database with courtesy of Ed Riley. And what you can see here is a DTI scan. And DTI is basically about diffuse attention. It looks at water tracks across the brain. And what you can see going from left to right. If I put my slide on here, can you see my arrow? Can you see the arrow, anybody?
Yes.
Yeah, perfect. So I'll do that. So what you can see going from left to right is the tracks are far greater and gets less and less as you get more severely affected individuals. And what it's showing is that there is direct damage to bigger parts of the brain. These are living children. This is a conglomerate slide. It's not an individual. This is about amalgamating different sort of groups and sort of giving the average look. But you can see even sort of just on the visual tracks, there's less on that and gets further and further. And the corpus callosum we know is definitely affected. But it's not just a structural thing that we need to think about. It's the functional aspects. And so using the bold techniques of blood oxygenation in fMRI, you can again see that there are differences. And this is basically copying a shape with one hand, and this slide is copying the shape with the opposite hand. So it's an opposite condition task in terms of having to think about doing something which you're not used to doing. So you have to use more cognitive effort to do the same task. But what you can see from controls and more severely affected, the more severely affected the individual is, the more the person has to work. Now, the difference to bear in mind here is the individual, most of us don't walk around with scanners on our heads that they're looking and seeing how much effort you're putting in. All you see is a child sitting there completing a task. You're not seeing the effort that's going into it, but the more effort you put in, the more tired they get, the less resilience they have, the more likely they are to have behavioral disturbance as a result of that wider cognitive load. So understanding that an individual FASD is going to be working harder to complete the same task give you some understanding into behavioral deficits and how to manage that from a very simple thing as do the hard stuff in the morning, give them more breaks. Something as simple as that could be a really useful intervention. The other thing that you see is that it's the higher level tasks that break down. So this is a task called number letter sequencing, which you should be going 1A, 2B, oh, they've gone wrong already. This is straight from a person from clinic. And what you've got is what you're having to do here is to use sequencing, planning, working memory, motor skills, at least 4 different cognitive tasks combined together to complete this. And it's when you add cognitive load to the individual that things start to break down. And you see that a lot, is that they can do simple things. As soon as you build up the complexity of the task, or when you bring in an environmental influence that distracts them and they have to think about that and monitor themselves, that they can't do it. And that's one of the things that you often see. I play guitar, and so when I'm playing guitar on my own, I find it far easier than when I'm playing in a band, because of the fact you're having to listen to other people and you make far more mistakes there, because the fact is that cognitive load increases. And it's no different here. It's that extra cognitive demand that we place on people that makes you more likely to have difficulties. Now, the other thing that we can see is this is not just in one situation. This is some data that we've published, which we looked at our clinic database in the blue line, which is from the clinic, compared to a similar study that was done in Canada by Fetal. And what you can see here is the profile using the brief is pretty similar in terms of where it goes up and down. And so the same types of profile are being seen, but all of them are generally, apart from organization of materials, are above the line for clinical threshold, and which just demonstrates that there is a significant deficit within that. So it's a brain-based thing is the first thing that I'm going to say to you, is that you have to think about the brain, and there is a fundamental underlying aspect that we know that those children and adults with FASD have ongoing wiring difficulties that causes them interface. And increasing what we know is that conditions are not about outcomes or in terms of such, it's about which pathways in the brain are damaged, the overlaps and the interface and differences between individuals is the nature and degree of those kind of things. And so one of the things that we need to understand, and this is a piece of work that we're doing at the moment with, and I'm part of, so Liz is on the group from Australia, I'm on the group from England, and there's mainly Canada and America who are part of this group, but the NIAAA brought together a group of people who have databases, who've published on databases, to try and look and say, could we look and say, well, what should the thresholds be? Because we define them as 2 standard deviations, but actually it may differ. And one of the things that we're thinking about here is, why is that? So if we take IQ as an example, we say, well, why is the cutoff 70 for an intellectual disability? Well, the reason is because it's 2 standard deviations away from the norm. Because in science, we describe that 2 standard deviation point is considered a significant level. That's why we use 0.05 as an example of severity. Now, what we're saying here is that bottom 2.5% represents those people with a severe level of disability, and that's where we've defined the cutoff as 2 standard deviations. But people don't work like that. People are not statistics. People don't necessarily have the function. And what you see is a whole group of people who may be above the line, have a very clear disorder, but a whole group of people who are not quite there and have got deficits. So somebody with an IQ of 75 may well still have a functional deficit in an adaptive behavior in the disabled range, whereas somebody with an IQ of 65 may not. And it's about understanding where that fits and where you define the line as a disorder. So if we're thinking about this, this is just 4 individuals as an example. And just to give you an idea of how we sometimes struggle. If you happen to be the person in blue or the person in red, it's easy to diagnose somebody because they're always above the line, they're always below the line. But the challenges that we face and why we have complexities, and in psychiatry it's even more complex because what we deal with is phenomenology, and we deal with which are descriptive symptoms, and we're going to come on to, is therefore how do you do that and define a cutoff? With FASD, there are cutoffs defined by psychological testing. Apologies if you can hear a buzzing. There's people doing work in the garden. It's early morning here, so they've started early. So what you have to think about is, how do we define that? So is the person who has difficulties in some settings but not in others having considered a disorder? Now that could be that actually here, that, for example, I'm talking very quickly and I'm not accommodating for the needs, that they just need slower processing, that it's not a situation. But in a situation where things meet their needs, they're fine. What about situations here where anxiety may be the cause of the reason why they drop above the line? And so therefore it's something different. It is not a neurological disorder, it's an anxiety related disorder that affects it. Which diagnosis are we going to give when there's an overlapping presentation? And what we know, and there's recent papers come out this just in the last few weeks looking at this again, is thinking about hot and cold executive function. Because what we do when we test people is we test people in a situation where there's no distractions, there's no external noise, there's no other things that are putting people off. You introduce that extra resource and that problem, and that emotional arousal then stops that person functioning. And we see that all the time in this group, is that in situations where there's no extra demands, people function. You add in that extra layer of arousal, that extra ray of demand, and suddenly things fall down. Because what we want to try and do is to put people into boxes, and people don't neatly fit into these boxes. So diagnostically, it becomes a challenge. And when we're thinking about phenomenological and neurodevelopmental outcomes, we need to think, well, what box are we trying to put people in? Or should we actually be thinking on a dimensional trait? And when DSM-5 came out in 2010-12, there was lots of papers in the psychiatric scientific literature at the time thinking about, should we move to a dimensional approach or should we remain in a categorical approach, trying to fit people into those boxes? And so that's something that we always need to think about, and we'll come back to how we think about that. So let's go back to the journey. When I started on this journey, one of the things that I was told and sort of got stuck with a little bit was, why is this not autism? Why is this not ADHD? How do these things relate to each other? And being a neurodevelopmental psychiatrist, so my whole world is neurodevelopmental issues, intellectual disability, you could argue to a certain degree is a developmental condition as well, is thinking about how these things fit and what the relationships are. And what we can think through is that our understanding of a lot of these conditions have changed. So our understanding of autism, if you go back to ICD-9 as infantile autism, and is very different to our understanding of ASD and being autistic at the moment. And there's something that actually, that aloof concept of autism is no longer what we think about. And what we now have is a wide spread of dimensions and severity, and within people who are falling in the ASD. So rather than being just a disorder. It's now a condition that people have and people live with without the deficits and the disorders, much more wider in terms of its presentation. ADHD was recognized far more classically even that, but even then the type of presentation doesn't always fit neatly with what we tend to see. And the concept of FASD when I started was more seen as an outcome separate to these, not as an etiological condition which actually linked to them. And so there's something about the literature and how it fits and the understanding of the relationship that was a challenge. And so you'll see lots of different rates quoted. So one of the biggest systematic reviews that were quoted found that ASD was only 2.6%. Well, how does that differ? When you look at our rates, we're nearly 70 to 80% of our group are having comorbidities. Now, one of the answers for that may be the fact that the next paper along, published by Temple in 2021, which showed that those people with the most severe presentations were far more likely to have comorbid ASD and ADHD. So as a clinic population, maybe it is possible that we are seeing that more extreme end, and the people who are not presenting, if you do a population-based sample, will have the lower rates. Or is it that the Lang study was looking at a different type of autism or a different type of ADHD, so isn't being picked up? And so if you look at the odds ratio that we see for autism in a more recent study published last year, you can again see that it's very high odds at nearly 7 times greater risk than the general population of having that. If you go back to the papers when they were first published and the very early publications, you can see even there that there are lots of traits of that ASD presentation, but just not labeling it as such and attributing it to a different scenario. So there were in people with FASD, the social communication difficulties, theory of mind issues, resistance to change, problems with communication and verbal and non-verbal. All of those are classic ASD traits, but they're not being labeled as such. ADHD, inattentive symptoms, forgetfulness, poor organization, impulsivity, talkative. These are all, again, parts of the descriptions if you go back to the early descriptors from the very early periods of that. So one of the things that, that I concede very early on was thinking through how this all fits into into this situation. And this is very much a behavioral phenotype model, thinking about how things fit. Now, when we in psychiatry work, we take a top-down approach to phenomenology. So depression, schizophrenia, bipolar, they are top-down diagnosis to phenomenology. They relate to the symptoms and functions, but they do not tell you what has caused it. When we talk about etiological disorders, whether they're genetic disorders, whether they're teratogenic disorders, these are the things that are causing damage to the brain and body as a syndrome. So you could talk about Fragile X, you can talk about Down syndrome, you can talk about a shank deletion if you want to get into the mechanism, that would be more equivalent of the alcohol here. And therefore, you're getting into the details of what is etiologically causing this kind of problem, leading to the symptoms. And so what I'm going to show you here is a series of slides which I created a long time ago, which kind of highlight that. So if I throw a bunch of executive function slides onto the screen and cluster them one way, you get the core symptoms of ADHD. If I cluster exactly the same symptoms in a different way, you get the core symptoms of autism. ICD DSM-4, sorry, we'll do DSM-5 now. DSM-4 basically said that we shouldn't have these two together. DSM-5 clearly says we are allowed to have them because science has moved on. If you see the descriptors in FASD, all of these things are described. And this was the start of my journey, is, well, if all of these is described, we should be seeing autism, we should be seeing ADHD, not in all, but in some. Because what we're talking about are these conditions that can lead to damage to those social communication pathways, which can lead to something that we call ASD, because what they're doing is damaging the pathway that leads to these types of symptoms. And what we increasingly know is that that genes do not code for conditions, they code for proteins, they code for pathways. And we know that that is what leads to the outcomes that we see, because there's not even 100% penetrance in any of these conditions. It's very much the case that there's other things influencing that. And what we're looking at are those things which overlap in damaging the pathways that we're dealing with. As an example, comparing it to Fragile X, which is a genetic syndrome, the most commonly inherited condition, what you can see with Fragile X is if you have greater than 200 repeats of the CGG on the FMR protein, you will get Fragile X. if you have 150, less than 50, it's considered normal, and that 150 base pair range is considered an intermediate syndrome. If you get diagnosed, some will have ADHD and ASD, if not most of them, but not all, and so you get other outcomes. And it's exactly the same. If you have prenatal alcohol exposure, leads to a diagnosis of FASD in some, not all, and those who are diagnosed will end up, some will have ASD and ADHD as an outcome, but most will go on to have other types of presentations. And you can see in the literature, it's not unique to FASD that there's a variation. And this was again taken from a paper. The FASD is our data at the time, but if you compare it to the data that's seen in other conditions, you can see the variability based on how people approach that and what criteria they've used in terms of the diagnosis of these other conditions. Looking therefore at what that means is then going, well, okay, if it's a different type, well, what does that look like? And so this is a piece of research that was done by Chris Oliver's group in Birmingham with the Cerebra group. What you can see is that looking at sociability in 4 different genetic syndromes, they found that if you have Angelman's or Rubinstein-Taybi, you have very pro-social approaches to individuals, which means if a stranger approaches them, they quite like being involved with them, actually makes them more vulnerable. But if you don't engage with them, they can get agitated. With Fragile X and Cohen-Delanga, they're quite aloof. So if they don't like strangers being involved with them, and they'll get agitated with you if you try to engage with them. So opposed approaches to sociability, all within a social functioning on the autistic spectrum. And FASD is a pro-social group. They very much like to be involved with people, but they don't always get it. So if you break that down in terms of the presentation in our clinic population, you can see only around, again, that very low percentage of people, of the 200 people who we've diagnosed at that point in our database, have more aloof type presentations. By far the most common is that pro-social, active, wanting to be with people, but not really modifying themselves to other people's needs type presentation. And that's far more what we see in this group, but it's not necessarily what you would expect. And if you're looking for just aloof type presentations, and it goes back to that assumption, is that 2% that was pulled out because people are looking for this? And I know there was a look for this. And so if you don't look for autism in that way, you're not going to diagnose it. And we know that that spectrum is grown. If we look at ADHD and break it down, again, inattentive symptoms are very high across the board. Now, the reason why I think this is lower is because we've got an overlap with ASD in that group, and they can concentrate on things that they want to concentrate on. But that inattention is quite high. Whereas if you look at hyperactive symptoms, it's lower. So you have an inattentive, impulsive subtype of ADHD. So a different presentation, a different formulation because of the etiology. So that's the bit which tries to persuade you there's a brain-based thing, you have to understand it, and that actually there are phenomenological aspects to it, which actually mean that as an outcome, it may well present as other things, but there's a good chance that you are seeing something. A bit like was presented by Alex, the child presented with neurodevelopmental issues, but actually to understand the individual, you have to look underneath it, say what is causing it and why are there differences, because the challenges of not responding in a typical way is because there's more going on, and you need to think about more than that. But it's never about one or the other things. It's never just about the brain. And so we need to think, well, okay, well, how does the environment then influence it? And when I first got into it, it felt very much that you had to be one or the other. You're either in the biological camp or in the environmental camp, and never the twain shall meet. And we all fought each other and sort of had big wars and stuff, but actually that's not how it is, because the reality is what we need to think about is how do these things influence each other and where are the overlaps, because the symptoms that we observe are related to both. So when you talk about PTSD, when we talk about those traumatic experiences and how they influence the individual, whatever the brain is, they're still going to experience that. And so you need to think, well, how do these two things influence together? So I came up with the phrase, the psychiatric onion. I like cooking, so I was cutting an onion and looked at the layers. Oh, that's an interesting concept. This is how we do things. They stimulate you and sort of give you the ideas. But what we're thinking about is that the thing I like about it is the layers. And there's lots of different layers. You get small onions with a few layers, big onions with loads of layers. And it will vary as to not the nature of those kind of factors, because you start with the root, which is the brain and the neurodevelopmental issues. That leads the individual to be vulnerable, which then are influenced by those environmental factors. And you can get lots of these layers, environmental factors, that will then influence them. So one of the things that people always talk about, well, it's all about attachment. It's all about that. Well, it's not just all about attachment. There's more to it, because actually there's something about, we all go through a period of attachment, but some people will have some biological basis to their attachment, other people won't. And what we know, if we go back to the basics, as a baby, 0 to 6 weeks is basically want to be kept warm, to be fed, to be clean, and generally they're contented. They will make noise and sort of get upset if things like that are not happening. 6 to 7 months, they will move between people and they will start to be indiscriminate, but as long as their needs are met, they're okay. And it's after that that you start to see that specific attachment due to multiple attachments. But if it's not going right and parenting isn't correct, then you start to get those kind of things. Now, that's where I would challenge it, because, and this is where it comes down to, is parenting style child response. What we're seeing here in neurodevelopmental disorders is that's not necessarily how it always applies. And so we looked at that in fetal alcohol, and there was only 7 studies, 2 for FASD. They were showing that you're more likely to have a disorganized type of attachment, irrespective of parenting in the FASD group, with if you had a basic. Now, if that's just one thing, so we wanted to go back and say, well, okay, well, what do others find? And what we looked at and found is that if you look at the autism literature in the Netherlands during that mid-2000s, there was a lot of research going on at looking at attachment in autism. And what they were generally finding is that you're far more likely to have an insecure attachment pattern if you look at it classically. And it doesn't mean they're insecure, it's just the nature of the style of how they react is like that. But in this bottom paper in 2007, they found that parenting, when they looked at 3 groups, those with intellectual disability, LD, and normal controls to those with autism, they found that the parenting group of those with autism was not related to parenting in terms of their attachment behavior. And some of that is to do with attachment is a social engagement approach. And if you have deficits in your social communication pathways, it could be inherently considered that you may well have other deficits as well. Now, looking at sort of that, therefore, the studies that were done to look at vulnerability and the impact of that in terms of the Romanian orphanage study have suggested that if you're exposed to environmental factors, it can cause autism. Now, one of the things we're going to come on to was that's not something that we were seeing in our clinic, and we wanted to explore that. But there was a paper done by Dinkler et al. In 2017, which looked at the Swedish cohort and looking at autism and adverse childhood experiences. And what they were looking to see is, does an adverse experience lead to autism, or does somebody with autism have more likely to have an adverse experience? And it was the latter, is that they found that childhood maltreatment didn't increase the likelihood of having a neurodevelopmental load, but if you had a neurodevelopmental condition, you're more likely to experience and be more vulnerable to outcomes. And that's what we were seeing. Now, in our clinic, what was happening is that we were seeing a whole group of people where you had prenatal alcohol and trauma and adverse experiences, and those people who had just PA and who were in good situations with no adverse experiences that were obvious. And if you look at that from a neurodevelopmental outcome point of view, there were no differences in the groups if you take into consideration no neglect, some neglect up to 6 months, and protracted neglect. And the 6-month point comes from this Romanian orphanage study, where they actually said that those people taken into care before 6 months had no difference. So we concluded that the neurodevelopmental consequences and the neurodevelopmental disorders were independent of neglect, and the neglect didn't make that neurodevelopmental, the neurological bit, any worse. It did something different. So when we think about that, we say, well, what we didn't have was just the neglect group, and you needed that to be able to say, well, what does that do? But that had already been done in a trauma clinic in the States by Honorary et al. And what he showed is that people with neurodevelopmental deficits were more likely to have also had the prenatal alcohol exposure. So if you had prenatal alcohol exposure and neglect compared to those 2 neglect alone, you're more likely to have a neurodevelopmental consequence, language problems, memory issues, processing skills, inattention, hyperactivity, social problems. And a recent paper by Dominic Mukherjee from Ireland showed that prenatal alcohol was more likely than psychological trauma to lead to that intellectual deficit. So again, more papers and more studies pointing towards the fact that the neurological deficit seems to be far more attributable to the prenatal or the genetic insult, and the psychological stuff is doing something else. So if we go back to my onion, and we think about the neurology, and that's causing your brain to be shaped in a certain way, well, what does that then lead to? And Alan Price, who was then my doctoral student, was looking at this, and what he showed in his study was that across the board, that using the adverse childhood experiences questionnaire, and I think there were some people from Australia who took part because it was an international study that he put online, that there was a greater risk across the board. Now, while sexual and physical abuse was higher in the controls, it was still something that was seen quite significantly in those with FASD. So high levels of vulnerability. And you can see that across the board, is that all the studies that have been published since 2009 looking at the combination of prenatal alcohol and adverse childhood experiences all suggest that those are likely to have greater comorbidities, greater risk of vulnerability, and that the early diagnosis and intervention is needed to change that outcome. So you need to think about both, that double jeopardy of both having a neurological deficit, which is prenatal in origin, and an environmental factor on top, thinking about that, which is leading to a greater level, and fits with the same presentation that was seen in that Dinkler study early on. Because what we're thinking about is that environment for healthy growth and healthy development, you need to have a brain that's working properly. And the picture was something I spent 2 years looking for, and our comms team found it within 2 minutes. I was speaking at a conference where somebody was talking about attachment, and he described for attachment to work properly, you need to have a healthy roots of a brain, and it's like a healthy plant, you need to grow, the roots have to be healthy. Well, if your brain isn't functioning properly, you're going to have some inherent differences in how that structures, and the biology is going to have an influence on that in terms of how that takes it forward. So what we think instead of is a complex trauma model, thinking about biology and vulnerability and environment together to think about how that all works. So that goes back to my psychiatric onion, thinking about the vulnerability, that neurological deficit, and how the environment influences that on top of it. And if you give an example, if we think about a child where we don't understand the brain, we don't understand that they have communication deficit and poor understanding, when they're not listening or they're not paying attention or they're not doing what they're asked to do, you end up with a description of being disobedient and blamed, and eventually a conduct disorder label. Whereas if we flip that and say we understand the communication needs to be adapted, and that other people need to adapt how to speak to the child or slow down and give them information in a written form, that will change that perception. And all of a sudden, they're no longer being disobedient, they're doing what they're told, and people function better quality of life, and those diagnostic labels to change. And you can see in the diagram, I don't know how well that's come out, is that you can have different layers with different things starting to influence that kind of situation. But you need to understand the experiences with the perspective of the individual first. You need to think about what is their way of processing, how does their brain work, and then what does the environment influence that on top of it, because that will give you an idea. So PTSD is a very valid presentation because traumatic experiences will be perceived differently by different people, and the significance of that may be greater because their ability to process these things is less. So you have to think about that in those whole kind of things. So what that leads to from a psychiatric presentation is greater levels of anxiety and arousal. And so anxiety and arousal is very common, and you need to think through how to do that. And the general principle of that is thinking about reducing anxiety, reducing arousal in a multimodal process. Because what we're trying to think about is if people are very high in their arousal levels, we've seen already that hot executive function aspect is something that stops people thinking. And what we're trying to do is to keep people in a regulated zone for as much as possible. And medication and treatment sometimes is about regulating arousal as much as it is treating an underlying condition. And what happens, and is an example why people present in certain ways, is if people are hyper aroused at certain times, you may find that they end up in situations where they have a psychotic-like situation, rather an acute and transient psychotic episode, rather than a schizophrenic type presentation. And it's those traumatic experience, that reliving of the situation, that engenders that. Now, that could be a sensory issue that's doing it. It could be a relived experience. It could be those triggers points in terms of that onion and the layers, and understanding that to say, that's the trigger here. So what we need to do is understand the trigger and either avoid it or do something to adjust and change what you're going to do to it. So they're the kind of things that you're doing, and you're trying to do is to basically bring the arousal level down. And a way that we do it is more based on a PBS type approach, but thinking about regulation zones and how to manage people. And what we would tend to do in terms of managing this is almost sit down with the families and actually get them to try and fill in, well, what is the descriptor of the behavior when they're most relaxed? What is it when they're slightly agitated? When they're starting to get agitated, but you can still just about manage it, what does it look like then? And what does you do when you completely lost it, and how do you manage it? What you don't do in red zone is to try and intervene even more, because you have to allow them to come down that ladder before you're doing it. And in the amber zone here is you're trying to intervene, and this is where rescue medication can sometimes help to bring people back into that. And your aim is to keep people in the regulated zone for around 80 to 90% of the time, understanding that it's never going to be possible to stay in that zone forever. And so having behavioral difficulties occasionally is normal. We all have it. If you ask my wife, she'll tell you I have behavioral difficulties all the time, but that's a different story. But the fact remains that we all have issues and we all do it. So it's never about never having a behavioral disturbance. It's about regulating and bringing down the frequency and the intensity of these things. And that leads to the so what, because actually, if you diagnose FASD, if you don't diagnose FASD and just diagnose one of these things, is it the same? Well, what we know is that there are differences in the presentation, differences in the management based upon how these things, and in Australia, you've got a consensus statement of management of your own in terms of some of the from the Psychiatric from ADHD. We produce our own consensus statement that was published around ADHD. Alex is going to talk to you more about the Canadian algorithms which have recently been published, and we've recently just started in the UK a parenting intervention study as a randomized controlled trial, looking to offer interventions for parenting across the board to give them a early intervention, 7-week intervention, cost effective, low cost, group education, which will allow them to go away and have some general problems for the majority. So it's only the minority who've got real difficulties need to access a further health system. Because the problem is, if you miss it, what happens is a person with FASD is complex, and all of these different factors influence the person and their arousal. So you have to think about the whole. And if you miss bits and you're only looking at the trauma, or if you're only looking at the brain, you're going to miss the complexity of the individual. And we know it's their function that is in deficit. And so here, their adaptive function compared to their age is often in many of these domains far lower using the Vineland. And long term, if you don't, this is the thing, if we don't intervene, these are the disabilities that you tend to see. And interestingly, there's been a couple of studies in the UK looking at the criminal justice system, which has shown that these situations continue to be demonstrated when there is no intervention. But what we now know is that if you can identify early, if you can build on strengths, if you can get the individual to be self-aware and to know how to manage and give them a hope for the future and to build resilience, we can see a change in that. And what we're trying to do is shift that deficit-based model to thinking about how do we build on the individual strengths to a strength-based model. And so that's where I'm going to stop. The book we published a couple of years ago now, and sort of kind of is an introduction for everybody and goes through a lot of this kind of stuff. But very much the case that that's how I perceive these kind of things. And I'm going to stop presenting there and hand back to Alex.
Thanks, Raja. So we'll just switch back to Alex before we break for questions. Thanks.
Yes, I mean, it's always just so energizing and inspiring to hear Raja talk. Sorry, I'll stay grounded and share my screen. Here we go. And we'll swap over again because that's what I did last time. Excellent. How are we? I think we're on. Yes, good. Only teach me once, or maybe twice, because I was taught before. Anyway, yes, I can't help but think of all the cases where you know, some of my colleagues who are probably more of the trauma paradigm than the neurodevelopmental, you know, the parents get the message, just parent better, and your child's mental health difficulties will be will miraculously disappear, and then it turns out they have an underlying neurodevelopmental difficulty. Or the young mother who spent 2 years doing circle of security, only then to have her son diagnosed with autism once he came into our service. Anyway, we move on. So back to Benjamin. He's our 11-year-old boy with diagnoses thus far of ADHD and DMDD and PTSD. And we've also confirmed that there's prenatal alcohol exposure. So what do we do as we're a little coastal town with a visiting pediatrician? We forged a really constructive relationship with the school, which is always fragile because the school takes a very behavioural approach, and they have the whole school to look after, whereas I go in there as the advocate for one child. I was very fortunate. School psychologist, the registrar actually, the psychology registrar, was very passionate as well. We got the ABAS and the WISC completed. to second what Raja was saying with this example, the IQ score was 80, and obviously not reaching clinical significance. But then still, one would expect, one's not surprised that he's having difficulties. Luckily, though, we reached clinical significance with the adaptive functioning scale. I had visions that we would get a brief completed, and we get the physio from child development to come over and see him, and that just stayed in my head. None of those things were able to happen, just lack of service capacity, long wait list in the public service as well. So we've submitted the NDIS application, which is great, and we're awaiting the results there. The really positive thing, though, is the way that the systems around him have come together, to use that Brennerian, I believe it's the MESO system, the way that the various other systems interact with each other, which is really positive to see. We have the school, we have the CAMS case manager, we have myself who does the occasional tweak, if I can use that term, but I'll talk more about that in a moment. The very caring and altruistic GP who wants this kid to really win, which is really great. We still rely on the paediatrician due to our state limitations in terms of child psychiatrists just don't prescribe. We just aren't part of policy. We just don't prescribe stimulants. That's always given to the paediatrician. And then what's great is that we've got some carer support who helped us a great deal with supporting the grandparents to apply for the NDIS. Respite's been graciously declined from the grandparents, which I also support, given the transitions are something he really does struggle with, and then they do access counselling from time to time as well. I just wanted to put up this diagram, the diagnostic collage, as I like to call it, when we see, something that I try to instill in the clinicians on the MDT in which I work, is that if we're seeing multiple, if we're thinking about trying to fit one child into a square, there's an analogy there that's not coming to me. But anyway, one should think about FASD when we see multiple secondary difficulties as well. I just want to talk very quickly about, because I'm mindful of time and the need for questions, but something that we struggle with in WA, and I don't know what it's like for the rest of the cohort attending today, but I'll speak from what I know, is just that lack of neurodevelopmental expertise and FASD as well, and guiding stakeholders away from that behavioural. This almost mirrors Raja's slide about how we move from one way of thinking to the other. We need to move away from a behavioural and conduct disorder perspective that will not, and move into a cannot, akin to the neurodisability that FASD is. And we need to also look beyond the trauma paradigm and look underneath that as well, and not just every child who presents with dysregulation has just had an extensive trauma history. There's a real lack of occupational therapy integration in our mental health teams. That's really just seen as a paediatric intervention. And so I would argue that if we'd get a lot more success and efficiency with our interventions if we took more introspective approaches versus just trying to talk to these children and not understanding why they don't want to sit down for an hour and talk their problems through. And then, as I've said before, there's very few stimulant prescribers as well, and very few, if any, for adults in the region which I work. Just the only other thing I wanted to add here, expectation management as well, but I'll touch on that when we go through the medication. This is the algorithm that's been provided by the Canadian FASD organisation. Very helpful, I find, particularly in explaining to people why when you meet this child, they'll be on 3 or possibly 4 medications, that polypharmacy is not uncommon in these young people due to the fact that FASD is a multi-domain neurodevelopmental domain condition as well. And so we will need to use a variety of classes of medication in order to meet the needs of this young person. But ultimately, lowest number of medications on the lowest possible dose for the shortest possible time. Those 3 caveats will always be in place, no matter what my prescribing might be. Maybe I should say. And then having said all of that, I've just included that fascinating step 5, which they say is for adults only, but I mean, you know, modeling full disclosure, I've used prazosin and propranolol very judiciously for children, especially when weight's an issue, in terms of using a PRN medication that's not got a weight gain propensity. And then also, I do like to use a small dose of mirtazapine at night time if we've got a child who doesn't have an appetite, who needs an anxiolytic and also trouble sleeping as well. But obviously very mindful that they need probably, you know, a quarter to half a tablet is my rule of thumb. I think I've said all about that. The only other thing is that this is to support and not replace social and behavioural interventions as well. It is about balance. I'm always surprised when I see someone stop stimulants in one fell swoop and then wonder why the child has rebound symptomatology. And then also, this isn't a set and forget. The child's brain is a dynamic milieu, and the balance needs to change as the person's health, environments, habits, and bodies change as well. And I use the term dynamic equilibrium, not in the literal sense, but the fact that we need to continue to monitor this as we go. The car does not drive itself, as I've once been told. And then lastly, just my take-home messages that I hope I can instill, in addition to everything that Raj has given us today, is that these diagnostic collages may represent those secondary difficulties that we see. And when we see that, we might want to peel those layers back, and this provides us with an opportunity to assess or even reassess for prenatal alcohol exposure and a possible eventual diagnosis of FASD. As I said, psychotropic medicine, when prescribed properly, can support but never replace social and behavioural interventions as well. They are the first line in that algorithm too. FASD is a brain-based physical disability, which is ultimately about modulating the environment, not necessarily fixing the child with enough medication. And as I said there, when we provide the right support, the person and their family can succeed with confidence and less frustration and ultimately shine in this world. So that's me done. Thank you. I'll stop sharing my screen.
Turning my camera back on. Thank you so much to Raj and Alex for those wonderful presentations. Always learn so much from you both. So now we do have time for questions, and I see that we do have one from Tina. So question on the neurodevelopmental domains at the FASD Hub. We are looking at expanding education around the domains in the FASD context. Firstly, would further education here be more helpful? And secondly, what kind of resources on neurodevelopmental domains would be helpful for health professionals? Don't know if either of you wanted to ask that question.
So you're talking about your 10 domains, aren't you? I think in terms of the diagnostic criteria.
Yeah.
And so in terms of educating around it, so the domains are kind of defined partly through the Canadian system. The cutoffs there are defined partly through clinical situation. That's what we're trying to do with this international consensus, and try and say, well, are those cutoffs the right levels? Is it the same? Because if you look at the Institute of Medicine criteria, they're slightly different in terms of some of these kind of things. So there isn't that international consensus that everything is there. Now, when you take that and the acceptance and the piece of work that your group did, and it was done also in Scotland with the sign guidance, which is what we use, which is pretty much the same, apart from a couple of tweaks. You know, it's about then thinking, well, actually, it's how you make sure other people know what to look for, how best to do it. So we did a piece of work called the Time Is Now document, which is out and available, which we tried to take the domains and map people to it, but that's from a diagnostic purpose. There is ways of actually saying this is how you can manage these kind of things to try and help. I don't know if that's what we're saying, but I think the answer is yes. It's always good to have education around them and actually ensure that people know what they're doing and ensure that they are aware and what to do and how to map things to it. But I'm not sure that's really answering your question, so I'm just rambling, so I'll shut up.
I was just going to hone in on affect regulation and how that is an executive function as well. I think people think about, especially, I don't think the DSM-5 helps either, which is why so many parents come saying that their child has bipolar, which always you don't say no straight off the bat, but you know, certainly you're going to head into the no answer, but you're going to start from somewhere else. But I just think calibrating professionals' minds that affect regulation isn't necessarily leading to a bipolar diagnosis, but it's much more helpful, I think, to consider as an executive function.
To add to that, depends on the interpretation of affect regulation. There is an inherent difficulty that some people have in terms of how they manage their behavior, how they manage their internal worlds and those factors. There's multiple factors that influence that. So executive function, the managing of that is one of them. You know, sensory could be another, processing could be another, environmental factors. It's a complex presentation. I think it's not one that is easy to score and to present with. And out of the 10 domains, people who've got the most severe deficits and the most obvious presentations will meet multiple categories, including affect regulation as part of that. So from a diagnostic threshold point of view, I don't think it's an essential criteria personally. I think it's something that commonly presents in people, and there's been that debate as to should it be in or should it not be in, and I think that continues to be debated internationally. It is a very common presentation that people with FASD have, because it is something that they struggle with because the world doesn't meet their needs quite often. And so, but there are underlying factors that will relate to that, as Alex points out. And so it comes down to should you or shouldn't you. The fact it's there, you know, if you're, what I always say is, if you're at a starting point and new to the journey, use what's there. When you're 20 years in, like I am, then you can start to have debates around should it be there or should it not. And it's there to say, look at this and say, well, actually, this is what experts have said are core and common in this group. I would start with that point, and then when you know more and have seen hundreds of cases, you can start to debate around, well, we don't see it quite as much, etc., etc. But that's where I would stand with that.
Thanks to you both. That's helpful. So we've got another question. How do you navigate the question of prenatal alcohol exposure in children in out-of-home care or kinship care when you aren't able to get a history of PAE from the mother directly? There's a possibility of others assume that there was PAE or have other agendas and say PAE when there wasn't. Yeah, I note in the case
You're pausing, Kirsten.
and audit C was done with the grandmother, so that must have been your case there, Alex. But yeah, do either of you have any thoughts?
I'm happy to answer, but I'll let Alex go first if he wants to.
Oh, I mean, I've actually sometimes asked for, through freedom of information. I mean, luckily in WA we're quite a you know, most children are born in a maternity hospital here, so I often find myself working with the legal department to obtain records. I've done that before with success. I had confidence in the grandmother because it was the maternal grandmother, and there wasn't any hidden agenda. I just wanted to say before handing over to Raja, I think sometimes the biggest problem I'm having at the moment is teasing out who's used alcohol and who's used other illicit substances, and then who's used both.
So my take on this is there's an aspect of this question that relates to difficulties asking the question, the stigmas that some people perceive as going to be there. There's something about not necessarily feeling comfortable asking, so therefore let's ignore it. I take it in terms of this is a lifestyle question. And so if you've got a birth mother or a family and you're just asking the question, well, my general developmental history starts pre-birth. And so I talk about lifestyles. What were your lifestyle like beforehand? Did you exercise? Did you generally have a good diet? Did you on any medication, any kind of smoking, any alcohol, you know, fifth or sixth one down the line that you're talking about? You're generally getting a lifestyle history in terms of looking at risk factors, because prenatal alcohol is a risk factor. Then you talk about when did you conceive, and did you identify the pregnancy early? Did you start it, or did you change? When did you change your behavior? Because people don't necessarily change their behavior at conception unless they're planning the pregnancy, and most pregnancies are not planned. And so therefore you're starting to look at the level of risk, and there can be risk at any point during the pregnancy. And so if you've got somebody whose general lifestyle is they go out drinking at a weekend, and I think you're in Australia the same as us in England in that we have a binge drinking culture, and that actually you go through and you kind of work out, yes, there was a risk before, you can start to identify the nature of these kind of things. Then you can go into, well, did you change your pattern of behavior? If so, when and how? What was it like postnatal, etc. The drug bit is complex, because we know increasingly that alcohol, in terms of long-term consequences, the most dangerous teratogen. Things like heroin and opiates cause less long-term damage biologically. Other things do. Our understanding of cannabis, for example, is changing as well in terms of its interaction and what it's doing, and it's to do with the THC component compared to the cannabinoids in it, and so whether the level of harm. And so you can start to pull apart some of this by the more information. We have exactly the same problem that you have, is that sometimes, especially in an adopted population or a population where the birth mother is no longer around, getting that accurate alcohol history is often really challenging. And sometimes you have to go through courts to get access to summary. Sometimes you have to rely on investigation of other people. And so we try and relate that risk in terms of levels of severity from no risk at all, probable, to definite kind of thing. And I can kind of use a 4-digit kind of approach in terms of layering some of that in terms of levels of risk, and then how you go into it. But that's kind of described in the diagnostic approaches. But it's information seeking, being inquisitive in terms of your narrative and history taking in a non-pejorative way, which is less stigmatizing, because you're just asking a good developmental history. And that's my approach.
Thanks for that. I'm just going to switch to, we had a question in the Q&A box. How do you broach the possibility of FASD with biological parents when the child has a diagnosis of autism and or ADHD?
So the situation that I always think about is there's two things. If we're talking about Down syndrome, you wouldn't have a problem, because it's a genetically sort of non-inherited condition that people have, and people with Down syndrome can have ADHD and ASD as well. So here what we're talking about is an etiological disorder that is created by a consequence of something the mother has done, and so therefore there is a stigma attached to that. Now, we've had situations where people have presented in prevalent studies were done where it's not been expected, but what they know is there's something not quite right with their child. They want to understand the child. And I always say, I want to understand causes as well as outcomes to the individual. And I want to try and explore, because we know that the cause of something changes the nature of how the outcome is. And we know that autism and ADHD is a spectrum representation. It's not a singular thing. And this can point us towards what other things to look for to best understand your child. And we use it in, again, an exploratory way. And it's not saying we're just looking for things. We know that alcohol is one of those things that can cause harm. We know it is a common thing that people do. It is preventable, yes, but there was a lot of times where, you know, back in the day, I'm going to be doing a history of FASD in the UK talk soon, and one of the slides I show is one of the big supermarkets in the UK, and you can Google this, were advertising for pregnant women to come and be wine tasters. So that was the nature of the UK's sort of a relationship with alcohol about 20 years ago. And so situations change based upon how society changes. I think a lot of people now will have an understanding that you probably shouldn't drink in alcohol in pregnancy, and they probably will have heard that message, which they wouldn't have done years ago. And so it's about exploring questions in a non-pejorative way, not trying to be blaming, but actually trying to say that. And if there is a issue that comes up, and alcohol is one of those factors, it's addressing it. And what people will do is that there may be grief, there may well be loss. You support people with their grief. You support people through the trauma that they experience themselves. You don't ignore it, because to ignore it, the mother themselves will know sometimes that this may have been part of the situation. And by ignoring it, what you're doing is not allowing them to work through that process and to develop a relationship. So we can show you birth parents where the relationship with the children are very good, because they've actually worked through some of that, and the relationship is very good, and there isn't always the ongoing blame and problems, because they know that actually that they are trying to get the best for their kids. And so it's something about not ignoring it, but doing it in a compassionate way that actually allows the person to work through it.
Thanks, Raja. Just trying to see which of the questions might answer. I think there was some crossover between a couple of them. I just wonder if we could go to Lee's question, which was related to Alex's use of cannabinoid. Are there specific allowances for its use for FASD in Australia? So Lee's from New Zealand.
I have not used cannabinoid myself. That was just lifted from the algorithm as a adult only step 5, where the indications for cannabinoid, for medicinal cannabis prescribing here, you need to be an authorized prescriber, and there needs to be pain or anxiety, and very few, if any, prescribers prescribe for under 16 here. I have had one young person with, excluding those who use medicinal cannabis for epileptiform disorders. I've had one young person who worked very closely with their GP. They had a functional neurological disorder that wouldn't respond to anything. Not FASD though.
Thanks, Alex. Just thinking back to Sue's question, which was just before Lee's, which is maybe partly answered previously, but do you think it would be helpful if it became common practice for health professionals to rule out prenatal alcohol exposure before considering ADHD, PTSD, or ASD?
I would say do it together. You should be, if you're taking a developmental history, you should be doing all of that, because it's the same thing. I would argue that we should be doing more genetic testing, to be quite frank, because I think we should be looking at etiologies far more often than we do. And as psychiatrists, we're very poor at it. But you know, I'm a behavioural genetics background. I'm just as interested in genetic syndromes in my wider work as I am in FASD, which is my special area. But I would be arguing we don't do enough etiological searching. So I think you need to think about the relationship between the two and how that changes what you see and how you manage it, personally.
Yeah.
I just wanted to say, in my experience with psychiatry, is that anything from the neck down is considered out of there. Sorry for not to be talking jest, but there's a real disconnect between a psychiatric presentation and what else could it be. And if you try to pursue the what else could it be, or what else is contributing, you're accused of being too biological and not thinking psychodynamically enough as well. So I think I totally agree with Raja, and I think we need to do more work with clinicians about how to, what I would call the on-ramp in terms of the questioning. People know what questions to ask, but you can even see it as you watch a registrar talk to a patient. They're just struggling to make that first question. And I think the way that Raja outlined it before, I mean, not to say do that, but I would do that.
Yeah.
We need to get more comfortable with asking, you know, although you're not the only person who contributed to your drinking, you're the best person to ask about it.
Okay. Thanks both. I think this will be our last question. Is there presentation similarities with other illicit substances, not just alcohol use?
So the answer is each drug. You have to stop seeing drugs as social compounds. You need to see them as biological agents that do things in the brain. So heroin, for example, works on acetylcholine circuitry and opiate receptors. They don't have the same frontal lobe activation, so they don't cause the same teratogenic effect into a frontal lobe action. GABA, sort of alcohol, causes GABA and glutamate damage, which is quite teratogenic, has midline structures and damage throughout. So if you start seeing these as biological components in the same way we're all familiar with sodium valproate and how that works in terms of that kind of stuff, and you look at the biological mechanisms, you start to see what they do and the level of deficit. Cocaine, for example, its K binding to receptors is very low, and so it actually needs a lot of it to cause a lot of cell activation, and so the real teratogenic effects comes with very high levels of that, and so you can start to break this down if you know the detail of that, you know, without trying to sell it. But we do go into this in the book chapter, and there are various reviews in the literature out there looking at different drugs and how that works. Like I said, with cannabis, the knowledge is changing, and as you get higher levels of THC into these compounds, the more likely there is to be neurological deficits, whereas the cannabinoid levels are less harmful, it seems, in a longer term way. And so there is, and people seem to, for some reason I've never understood, report the drug exposure but not the alcohol, probably because alcohol is socially acceptable and you miss it. But in terms of the literature and the reviews that have been done, alcohol causes this most significant damage of all the drugs out there. in terms of that long-term consequence. But it's not to say that things can't have an overlap, and if they overlap, it's a compound effect. So cocaine and alcohol will both activate frontal lobe aspects, and you'll have a compound effect in that. And sometimes you just can't pull it apart fully. But what we think about increasingly is what is the primary etiological cause leading to this type of presentation that best explains it. And sometimes in a mixing pot of people where you mix it all together and pour it out, it's a bit of both sometimes, unfortunately. We just
I just
messy.
wanted to very quickly give a plug to Raja's book. It's excellent. Buy it, read it.
Great.
Thank you.
And then also a plug to the course, because I know that Kirsten, when she was teaching us last year, she gave us a great little matrix, I think adapted from Malbin or Malbin. It's Malbin 2015. I don't know how to pronounce it. I do apologize. But it's got a lovely grid with some various neurodevelopmental domains, and then the drugs listed on the horizontal axis, and alcohol obviously lights up the most boxes on those domains as well.
Yeah. Thanks to you both. So sorry, I'm just making sure I've collected everyone's comments there. We have had some comments that have come directly to both, just sort of to the host. So we've definitely seen all those, and thank you all for your comments there. We've definitely read those, and hopefully everyone that wanted their questions answered live, that's occurred for you, but please let us know if that's not the case. Thanks to everyone. I know that everyone's in completely different time zones, so it's not so bad for myself and Alex and others from Perth. It's just edging on 5 p.m, but it's super early for Raja. For those who are in New Zealand,
It's nearly 9 o'clock now. I can start work
it's not
now.
so bad now. Yeah. And then those over East as well. So we really, really appreciate you all being here today. And yeah, thank you all for sharing all of your knowledge. And I just, again, thank you to APSAD, who've been a huge help in organising this, and again, encourage anyone to join this FASD special interest group if you're able to. Wonderful. So I think we'll leave it there. I hope you all have a great day / evening, and I'm sure I'll see you all soon. Thanks all.
Bye-bye.
Bye.
Yeah, bye.